I would like to welcome our great experts, Dr. Brigadier Sharma sir, who is a legendary gynecologist and very humble teacher. You know him very well, so you need no introduction. I welcome Dr. Sharda Jain ma'am, who is teachers of teacher, a great mentor, exemplary surgeon and IVF expert. Welcome ma'am. Now I welcome our other experts, Dr. Jyoti Agarwal ma'am, who is Senior Consultant Director, Life Care Hospital. Dr. Seema Sehgal, who is Director, IVF Center, It's My Baby, and MS MKW Hospital. Dr. Nimphea, welcome Dr. Nimphea, who is Consultant Infertility at Fortis, Shalimar Bagh and Ridge IVF, who is Web Editor of IFS and Forum Coordinator of DGF. Now I would welcome our first speaker, Dr. Poonam Agarwal, who is Director and HOD of Max Hospital and Panchsheel, who has edited many books and authored many books. She has received many awards. She is past president of IMA, past member of PCPNDT Advisory, and past member of Infertility Committee, FOXY. Welcome, ma'am. She would now speak today. Hello, ma'am. Yeah, she would now speak today for our latest stimulation protocols and how we can achieve a higher success rate in the IVF cycles. Over to you, ma'am.
Thank you, Dr. Megha. Is my screen visible? Should I start?
Yes, ma'am, it's visible.
It is visible. ये hide वाला हटा दो जरा सा वहाँ पे टिक कर दो बस.
Hide वाले पे. अच्छा.
That's it. Done.
ठीक. So now let us start with mastering ovarian stimulation for IVF. For that, we need to understand physiology of ovulation. As a surgeon or as a gynecologist, when we joined in gynae, my mentor, he told me that for a better surgeon, you need to understand the pelvic anatomy and you must give tissue their due respect. And similarly, I would say in IVF, we must need to understand the hypothalamic, pituitary, ovarian and uterine axis and also give due respect to all the hormones which have interplay in this. Ovarian follicle development is tightly regulated by crosstalks between cell death and survival signals. Depletion of the ovarian follicular reserve starts during fetal life and continues throughout the lifespan of women. Only a small proportion of the primordial follicles will reach the ovulatory stage while the rest will undergo atresia. Like here you see so many number of primordial follicles and at the end we get only one pre-ovulatory follicle. There is a role of FSH, LH that we all know. With that, there is role of interleukins, there is role of insulin-like growth factors, nitrous oxide, epidermal growth factors in achieving the pre-ovulatory follicle. Complete follicular development takes 220 days or more and has 3 distinct phases. That is initial recruitment of resting primordial follicle, then development of pre-antral and early antral follicles, cyclic recruitment of a limited cohort of antral follicles followed by the selection of a single dominant follicle. These all steps are independent of gonadotropins. The decrease of luteal estradiol and inhibin A following regression of corpus luteum leads to a transient rise of serum FSH, thus follicle recruitment is induced. Following that, there is peak of estrogen, which then gives a negative feedback. Then there is second peak of FSH and LH peak, which gives the maturation to the follicle. So that is how the ovulation takes place. But now it has been seen that follicles, they grow in waves. Today we understand that there are 2 or 3 waves of antral follicles in each cycle. The newer options for ovarian stimulation and oocyte retrieval by making full use of follicular waves of the patients either having normal or abnormal ovarian reserve. And now we are changing our protocols and challenging the conventional protocols. The whole story is of 2 cells and 2 gonadotropins. And the concept that stimulation of both theca cells by LH and granulosa cells by FSH is required for adequate secretion of estradiol. A predominantly estrogenic intrafollicular milieu will permit and favor the follicular growth and development, whereas excess of androgenic milieu will lead to degeneration and atresia. The follicle threshold and window concept. Each and every follicle which is present in the ovary and it needs a fixed threshold level to get recruitment. So for that, when we increase the FSH levels, and FSH levels are kept increased by exogenous FSH to a longer period, the window of recruitment will become of more number of days. And when there is no exogenous FSH, then that window will be of 2 to 3 days only. And similarly with mild stimulation, something between these two. And with LH, we all know that LH threshold and LH ceiling, and whenever there is LH levels which is lower than 1.2 international units per liter, then there will be impaired follicular growth, impaired oocyte maturation, inadequate androgen and estrogen synthesis. Whenever it crosses the ceiling, then we will have follicular atresia. We may have premature luteinized follicle. We may have suppression of granulosa cell proliferation, and oocyte development obviously will be compromised. So LH levels are to be between the threshold and less than the ceiling levels. So follicular output rate. Sometimes the follicles are much more sensitive to FSH levels. Like in the upper picture, you see only 30% of follicles are sensitive, and only so many out of so many follicles we only get 5 follicles. Whereas in the lower picture you see there is 80% sensitivity to the FSH, and there is adequate response, and we see 5 follicles dominant out of only few follicles which we see. So follicle output indices we measure, that is whenever the follicle output indices is less than 0.5, that means if half the follicles are not being recruited, that means there is something wrong in our drugs, or something wrong at some place. Maybe we are giving low gonadotropin starting dose, maybe there is genetic or environmental factors interplay, or in asynchronous growth of follicle is there. So once the follicle reaches 6 to 8 mm, the granulosa cells begin to express LH receptors. Concomitantly, the pulsatile LH secretion is there, and it increases with time. Estrogen secretion and follicular development continues even when FSH is stopped. It suggests that development of larger follicle is completely independent of FSH. As we all know that once it crosses the size 14, then it doesn't need FSH. Now, types and mechanisms of action of ovarian stimulating agents. We have come a long way from clomiphene to now in 2022, we have many things in our armamentarium. So now the gonadotropins, which we have, the urinary ones, they will have only 3% of glycoproteins, whereas 97% are other proteins. In the 75 international units of urinary HMG, you will have 75 international units of FSH, LH, and plus some detectable amount of HCG is also there. So urinary products, we will see that urine collection and processing is difficult. Source control is not absolute in these products. End product is always contaminated by more than 95% non-human proteins. LH contamination, even in the purest form of urinary products, batch to batch inconsistency is there. There is low specific FSH activity. Presence of FSH inhibiting substances in urinary FSH is there. Then recombinant ones. There is no batch-to-batch variability, more than 99% pure with highly specific biological activity. Pregnancy rates may be higher if frozen thought transfers are also included. And then route of administration is very convenient, subcutaneous, even pens, etc. as there these days, which patient can take at home. So it becomes more patient compliance. So key factors between the antagonist and agonist. There is no initial flare effect, no estrogen deprivation symptoms, shorter treatment protocol, reduced gonadotropin use, there is flexibility and reversibility in the protocol. There is recovery phase which is shorter than 2 to 4 days. Patients are more likely to drop out of agonist regime. That is also there. So factors affecting fertility outcome are age, ovarian volume, number of antral follicles, ovarian stroma, blood flow, FSH, LH, estradiol, inhibin B, AMH, substance abuse is also important, and body mass index. So major our biomarkers are age, AMH, and AFC. AMH and AFC will tell us about the quantity, and age will tell us about the quality. So this is another figure where you can compare the age and see that when the patient is younger, the follicular phase is longer, or the normal follicular phase of 14 days, where more number of follicles can be recruited by giving a specific FSH dose for a number of days. But when in an older patient, we are not able to retrieve all the follicles and they become atretic. Even if we are giving the dose and the follicular wave is shorter, that is why the shorter cycles are there in these patients. So our stimulation depends upon the ovarian reserve. The recruitable number of eggs, as they increase, our stimulation drugs, their amount starts decreasing. So factors which predict ovarian response, as we studied those factors, and over and above, the genetic traits and abnormalities are there. Abnormal variants of FSH receptors are sometimes there. There is mutation in the gene coding for FSH and LH receptors, which is sometimes responsible. So now, after understanding the physiology, knowing the armamentarium, and now we have assessed our patient's profile, what should we do to make it perfect and nothing goes wrong? So for that, we need to understand what is our aim. Our aim is to have optimized ovarian stimulation with best protocol, with best results, which is most suitable to our patient, which has reduced cost, and it should avoid the complications. What we need a uniform cohort, we need synchronous growth of follicles, we must avoid the follicular dominance, good quality oocytes are required, timely induction of ovulation should be done, and adequate endometrial development should be there. The cost effectiveness and safety is also important. So what steps we need to take? We choose the right approach for the right patient, a moderating approach in high responding women, a maximizing approach in normal responding, a creative approach in reduced responding women, and we should have correct number of oocytes to maximum our cumulative live birth rate, and we predict ovarian response, and individualized protocols are to be used these days. So for using AFC with a pragmatic approach to choose the correct starting dose of gonadotropin becomes very important. When the AFC is less than 10, we may have to go with 300 IUI of FSH or HMG. And when there is normal amount of AFC, that is 10 to 15, we may go with 225. And when a lot number of AFC or enteral follicles are seen, then we may have to go with 75 or 150. And we must take age and AMH also into account. When to start? There should be no functional ovarian cyst at the time of the ovarian stimulation. And day 2 serum estradiol we can have, they should be less than 50 picogram per ml. Once ovarian cysts are there, the aspiration does not improve the result of stimulation, but we can downregulate the patient with prior COC use, or surgery can be envisaged only if the presence of large cysts are there. And sometimes the inherent cysts are there which are not active, then we may go with, if we are seeing the cyst, then I think we must have the serum E2 levels before starting the stimulation. Whenever there is pre-existing endometriosis, we need to consider the change in stimulation protocol. Long down regulation protocol can be used. Surgery only. In presence of large endometriomas, consider and counsel about ovarian reserve, or maybe to treat concomitant pain symptoms which are refractory to medical treatment, or when malignancy cannot be reliably ruled out, then we have to go for surgery. Maybe it can be done after OPU before frozen transfer. Now, choosing the right protocol. Is there any right protocol for every patient or for your patient? No, there is not a fixed protocol for every patient. It has to be individualized according to the patient's profile. What is the difference between the various protocols? WHO made a study and they came out with that there is evidence to suggest that mild stimulation was more cost effective than standard IVF, which conventionally we were doing earlier, and now also in between we are doing, based on a reduced number of ampules and total dose of gonadotropins. Mild stimulation was also associated with a reduced number of oocytes retrieved, which may be having implications in the form of that we will not have surplus embryos eligible for cryopreservation. So we have to make a balance between the two things. Now the stimulation, natural cycles, single oocyte, no medication is required. Modified natural is we aim to get single oocyte, and we can have little modifications with the use of some medication like HCG or add back FSH, then mild stimulation, we want to get 6 to 7 oocytes, and we use softer protocols for that. Conventional, we go for more than 8 oocytes. These are the protocols, that is antagonist and agonist protocol, that we all know. That's not a new thing. Short flare-up protocol. GnRH agonist is started on the day 1 or 2 of the cycle. Exogenous FSH administration then is started on day 3 of the cycle to continue follicular stimulation. Meanwhile, complete pituitary destabilization occurs. What are the advantages? There is shortening of the stimulation time, reduced amount of GnRH is used, and total cost will be less. Ultra short protocol is then when we give GnRH agonist only for 3 days. LH suppression is not needed in these cycles. This protocol will help to retrieve more oocytes. Ultra long protocol that we used in cases of severe endometriosis. GnRH can be given 3 months prior to the start of HMG, and then pregnancy rate appears to be improved in this subgroup of patients with ultra long protocol. Now, selection of protocol for your patient. For normal patients, as we already discussed, that we will go for 150 or 225 of FSH or HMG. We may go for agonist or antagonist cycle. High responder, we prefer antagonist cycle, and we would like to give the agonist trigger. But for low responders, there can be 2 groups. We have to take care in the low responders, that they can be very poor responder, or they can be suboptimal responder. So according to that, we need to give 300 or more than 300 international units of FSH. Though these days now we are sticking to 300 international units of FSH even in the poorer ones, but the stimulation may go for longer number of days, because the studies and various meta-analysis, they have shown that even the use of 450 will not improve your pregnancy rate. So types of gonadotropins, that we must consider what type of gonadotropin we need to use for our patient's profile. If our patient is PCO, we can use FSH or recombinant FSH. If our patient is poor ovarian reserve, we must go for HMG. And we can also use adjuvants in these patients. If cost is an issue, then we must not use antagonist, and can start the cycle with the oral progesterones to block the LH and then do the freeze all. So we must consider everything before we start the stimulation of the patient. So what are the different types of gonadotropin, what effect they have? The overall conclusion is that both urinary gonadotropins, mainly HMG preparation, and recombinant FSH have similar efficacy in terms of achieving a pregnancy or live birth treatment cycle. So that means there is no difference in these two. No, there is little difference, because different RCTs and meta-analysis, they show that different types of gonadotropins, they give different yield of oocytes. Your recombinant will give better yield of oocytes, but at the end of the day, as of now, the studies suggest that cumulative live birth rate is similar with the use of both the drugs. So we need to assess what we are to use. Now, how many oocytes we require? Number of oocytes required to obtain an euploid blastocyst will be affected by the maternal age. At the age of less than 35, if euploidy rate is 60%, as the age advances to 42 or more, the euploidy rates falls to 20%. That means we will require more number of oocytes to get one blastocyst, which is euploid. So how many oocytes we require for good outcome? A novel predictive model to estimate the number of mature oocytes required for obtaining at least one euploid blastocyst for transfer in couples undergoing IVF and ICSI. The ART calculator can be used. This is a very simple kind of a thing which is available on the net, and it is free of cost. Everybody can download it, and you just have to fill the requirements which they need, and with one click they tell you the result. Like in this I did, and they said that the ART calculator predicts that the probability of having one euploid blastocyst with 7 mature oocyte is 54.72%. So I will need for one mature euploid blastocyst 11 mature oocytes. So the more oocytes, the higher chance of complete to complete an average size family. This is another aspect. How many oocytes are optimal to achieve multiple live birth rates with one stimulation cycle? That is one and done approach. That means we are not sticking to 1 or 2 blastocysts. We are trying to make 4 or 5 blastocysts. So with one fresh cycle with high oocyte yield, we can plan with modern cryopreservation the concept of one and done. That means the patient can achieve 2 or more live births from the yield which we got from just one stimulation cycle. And this we can achieve in almost 1/4 of our patients. This is another, they have evolved some other index, that is AMH into AFC divided by patient's age. It is called ovarian response prediction index. There is a nomogram. According to that, you can just map out how much FSH will be required for your patient. So all the things we have discussed. Now, what is the future? The genotype of the patient and other markers might decide the dose and success of your ovarian stimulation. There is FSH polymorphism. As we discussed earlier, the FSH receptors gene is thought to play a significant role in the success of ovarian stimulation. It can be used as a marker to predict difference in FSH receptor function and ovarian response to FSH. The patients with unfavorable genotype will require higher doses of recombinant FSH for giving the same stimulatory results. The FSH gene contains 2 important single nucleotide polymorphisms in exon 10 that change, where there is change of 2 amino acids at position 307 and position 680. Women with a 307 alanine and 680 serotonin, these are associated with reduced COH outcome. The 680 SNP series specifically is associated with lower clinical pregnancy rates, even if you get oocytes then also. So we can say genotyping the FSHR receptors and together with some additional novel markers like transcript levels, it may therefore provide a means to identify a group of poor responder patients before infertility treatment is initiated. Similarly, there is LH polymorphism, and also the LH receptor gene is known to carry as many as 282 SNPs. The patients with mutations will require exogenous LH additionally during the ovarian stimulation phase. Then the use of corifoliotropin. It is effective as recombinant FSH in terms of live birth rate, ongoing pregnancy rate, and clinical pregnancy rate. The increased number of eggs retrieved under this regime reflects the elevated effectiveness of this novel FSH formulation, but at the same time, it warns us against the increased risk of OHSS also. So we need to weigh our cost, our possibility of OHSS, and then use the drugs. Androgens, as we discussed earlier also, are needed in adequate amount. If there is higher amount, there will be follicular atresia. If there are low levels, that will give a poor cycle result. Although their action in promoting FSH-induced granulosa cell differentiation points to a potential therapeutic role, in few studies have addressed androgens as adjuvants to ovarian stimulation for IVF, but we need to do it very carefully and select our patients carefully for that. So now from pharmacokinetics, we are now moving to pharmacogenetics and pharmacogenomics. Pharmacogenetics is the role of genetics in the drug response, and pharmacogenomics is that it is the science that allows us to predict a response to drugs which is based on the individual's genetic makeup. This may not be very important in other fields of medicine, but I think eventually it is going to be very important in our field of medicine. The fixed dose versus individualized protocol, I think we have moved now to individualized protocols in our practices. There is newer approach coming, that is time to birth in IVF, and that is when the first time the treatment was started and then the patient got live birth. That is initiation of IVF treatment to live birth. Then OHSS free clinic, for that we need to do segmentation of IVF treatment. Segment A is that we must optimize our ovarian stimulation protocol. Segment B is to do the pickup and cryopreserve, and segment C will be that then doing it in a natural or artificially created hormone cycle. Then freeze all or freeze for all. So here we see that as compared to fresh transfer strategy, the freeze all strategy resulted in a similar cumulative pregnancy live birth rate among high responders, but significantly lower rate in suboptimal responders. So universal freeze all strategy may not be warranted. So we can just see that in which we need to freeze all the embryos, we may not do freezing for all the patients. So what are the advantages of freeze all strategy in high responders? There is higher live birth. The receptivity of the endometrium is not hampered due to the supraphysiological levels. There is reduced risk of or almost nil risk of OHSS. It improves the embryo implantation rates also, and fewer miscarriages eventually. This is our Poseidon criteria, where we all the times we are struggling with the group 2 and group 4 patients. But if we just take into consideration, we will be better able to counsel our patients. This indicates that older the patient, the higher the number of oocytes, the embryos needed to increase the chance of having at least one euploid blastocyst within the cohort of embryos. So now how our approach is changing. Conventionally, we had more oocytes, supraphysiological E2 levels, agonist protocols, more embryos, OHSS, and multiple pregnancies, and had cryopreservations. But today we are doing mild to minimal stimulation. We are getting less oocytes. Optimal amount of E2 is there. Agonist protocol is the choicest protocol. There is no HSS. There are no multiple pregnancies. The cost has been decreasing. Now, what is there in tomorrow for us? In tomorrow, the individualized protocols, which may depend upon their genetic study, and there will be obviously no OHSS, no multiple pregnancies, lower cost, and this is the most patient-friendly thing. Now, what are the key messages? The initial assessment of patient should be done on the basis of Golden Rule 3A, age, AMH, AFC. Always view previous record of stimulation before you start your stimulation. Our aim of COH is to get uniform follicular growth, quality balancing with cost and safety. Better to opt for individualized protocols rather than fixed for better results and less complications. Take help of things like ART calculator so that couples are better counseled about what to expect out of their stimulation cycle. Freeze all in hyper-responders. FET not only reduces the risk of OHSS, but also improves the reproductive outcome of IVF cycles. Modify your protocols as well as counseling according to pre-existing conditions like advanced endometriosis. Use of recombinant gonadotropin is a better option, but urinary gonadotropins is also as good. So you need to consider the cost also. So best is to stick to the evidence-based medicine, and we should collect and analyze our data, our results on regular basis to learn from our own shortcomings and mistakes. Thank you. So now I'll have to hear from my masters, my experts. Let me stop share. Malti, how do I do stop share?
Just go on the top of it. डॉक्टर साहब आपने
नहीं दिख रहा,
मिनिमाइज कर लो,
अपनी पीपीटी बंद कीजिए।
अच्छा बंद कर दो। ओके ओके, सॉरी सॉरी सॉरी, आई गॉट इट। ठीक है ठीक है,
अब यहाँ से मिल रहा है वो स्टॉप शेयर।
ठीक है ठीक है, मिल गया। हर बार कुछ कुछ गड़बड़ हो ही जाती है।
ब्रिगेडियर शर्मा प्लीज।
Congratulations, Dr. Poonam. It was a very nice lecture. You have covered, the whole gamut of stimulation protocol to get good results in IVF.
Thank you,
Just
sir.
to simplify it further, I would say what is a good, protocol giving good result. So our aim should be that we should get 10 to 12 eggs. That is the best So whatever protocol we use, so we should try to get 10 to 12 eggs in that particular cycle. So you are expected to have at least 70% fertilization. So you will have about 8 to 9 embryos, and out of those 8 to 9 embryos, you are likely to get 5 to 6 good blastocysts in a younger age group. So you are able to transfer in that cycle, and the balance you can use it subsequent cycles, so that the cumulative pregnancy rate can increase. Now further to decrease the cost of the treatment, what you can do is that flare protocol can be used. So initially, so that you can reduce the doses of your gonadotrophins. In the first 3 days, you give the GnRH analog, decapeptyl or a lupride, so that the dosage of your FSH, recombinant FSH which you are giving can be reduced. The cost of treatment can be reduced. So the first was to to prevent complication, OHSS. Your aim is to have 10 to 12 eggs, so that you can have good cumulative pregnancy rate. You can do fresh as well as the frozen transfer. And secondly, to decrease the cost of the treatment, which is also the aim. So you can use the flare protocol, and then the freeze all is a very good option, especially where you are suspecting the patient is likely to go to ovarian hyperstimulation. And finally, to the patients, especially those who are having the PCOS, what we find is that you may get a lot of follicles, and maybe a good number of which is not your actually good aim to get more oocytes also, but most of them may be GV or M1. So we have to understand the folliculogenesis and the follicular environment, because in the PCOS patients, and elderly women, there is an increased amount of reactive oxygen species in the follicular fluid. So we may have to, give them antioxidants, so that we get, good number of mature oocytes. So even if I'm, aiming for 12 follicles, I should get 12 mature oocytes. So if the age is higher, or if the patient is a PCOS, or if there's a previous history of missing, so antioxidants can be given to these patients to reduce the ROS in the follicular fluid. And subsequently, the final thing is that our aim is to get a singleton pregnancy.
Yes.
So we find one picture coming in the Facebook or in this thing, 3 babies born. I would not call it a success of IVF, I'll call it a failure of IVF. So our aim should be to get a single live, healthy baby out of that, so that even NICU admissions and subsequent, morbidity of the baby also can be reduced. So that is also our aim of the IVF program. So keeping everything in mind, so one can, choose the type of drugs, the amount of drugs, and also, to improve the quality of the oocytes, and also look into the male partner, because finally he also is contributing 50%. This thing, and nowadays we find that the DNA fragmentation is a very, very important test, which should be done routinely, like semen analysis before IVF, because even with the normal semen count, one may have a high DF5. So to get the good result, because finally the topic is how to get the good results in the IVF with the stimulation. So the male factor also should be taken into account. Thank you very much, and you did very well. And
thank you, sir.
And especially, I really appreciate the one point which you brought in was the stromal vascularization.
Vascularity, yes.
Because that is very, very important. And if
routinely we miss that, we don't see it.
If you find there's a highly vascular stoma, this patient is definitely going to give you very high yield. So you have to reduce the dosages in this patient. So color Doppler studies on the day 2 is a very, very important, which can help you in deciding the the amount of gonadotrophin to start with.
I think Dr. Poonam, after a long time, I read a very balanced presentation on what should be the ideal stimulation protocol. And I, as a teacher, feel that We talk about individualization, individualization, and individualization. But the end of the story is that in 95%, it is the same protocol we are using, same principles. At the end of few years of experience with IVF, I can say that what are the two facts which determine the success? If you do a blastocyst transfer, at least the 50% pregnancy rate is assured. Secondly, I find in FET transfers, again, the 10% success rate is increased. So, Sir has very beautifully highlighted that you should use a protocol where you get about 10 to 12 eggs. And I have seen if patient is of a normal age and the egg quality have been good, you find good 9 mature oocytes you get, and you will be able to get about 4 to 5 blastocysts, which you transfer to this time, and you can keep it for the next time. But here I just wish to tell you that all fertilized eggs don't make blastocysts. That part must be clear. I think maturity is there. And all blastocysts does not mean they are genetically all right. And third is, healthy blastocyst does not promise 100% pregnancy rate. It always remains 50%. It is the competent embryo or a euploid embryo which is going to make a healthy pregnancy. And no lab, IVF lab, can provide you healthy embryos from the unhealthy gametes. So that is, whatever you bring, that is it. And you have given a concept of 3A, age, AMH, AFC, and along with that, I am a very strong believer of DFI. If your DFI of the gentleman is not all right, I think, everything, whatever you want to do it, things definitely get compromised. And the story has been, we have been all trained by Brigadier Sharma, and he says that, the first 4 days, if you use a recombinant FSH, things are great.
Yes.
You can achieve everything. But slowly our concept is changing, and I find HMG is good enough in people who are young and who have, reasonable amount of things. It's a poor responders which are giving you problems, but I think this is what, the art which you have to refine, because tomorrow it is going to be more and more patient with poor ovarian reserve, and you must develop a skill.
Yes.
Here I do believe that Brigadier Sharma's students are all around, and they have a set mind. But यही protocol use करना है. Poor responders के लिए use करना है, इसके लिए normal responders के लिए ये करना है, और hyper responders के लिए करना है. I think that kind of a policy is there, and I over a period I have watched and analyzed patients. 11 days का protocol चाहिए stimulation का. That's it. Only in 5%, or I will say less than 5%, the stimulation protocol goes to 12. And I find, IVF should be kept simple. Less and less of adjuvants. We talk so much of adjuvants. I think less and less of adjuvants should be used. I will like, in the end, Professor Brigadier Sharma to make a comment on this. So I think with this particular thing, I think it had been a wonderful lecture listening from you, Doctor. You have really worked hard.
Thank you, ma'am. So now I invite Dr. Nimphea, ma'am, please.
Jyoti is busy today, and Nimphea, your comments.
Yes, Dr. Poonam, actually the lecture was very nice and crisp. Not just to say, and I mean it, it was very nice lecture. And the only thing is that everybody knows that we have to avoid hyperstimulation. But we recently had 2 referred patients of hyperstimulation. So it was just a point to make that we should now in this era absolutely have an OHSS-free clinic. It is absolutely manageable. So that patient was a PCO, had a fresh transfer, and she was receiving an HCG as a luteal support. So it is very surprising for me. So that's the only thing, because it is a recent thing which has happened with us. So I just thought that it is important to highlight that OHSS should be a thing of the past now. That's the only thing, ma'am.
Again, I will ask Brigadier Sharma to comment on it, that, with NTAC cycle, agonist protocol, and still all freezing and still patients getting into OHSS, what should be done about that? Dr. Bali, you want to make any comment? Dr. Bali, you are
Unmute, please.
Mute yourself. Unmute yourself.
Ma'am, wherever there is a follicle number which goes above 10, our policy is to use agonist as a trigger
Agonist.
and start immediately the protocol where, the patient, we have not seen OHSS now in our clinics. It was earlier in 2010 to maybe 2013 when I saw OHSS when I was working in Fortis. After that, when we switched over to these protocols, I think the clinics are OHSS free. HCG is the culprit, and if you know when not to use HCG, I think the clinics can be easily managed becoming an OHSS free clinic. I can vouch, last 8 years I have not had.
So absolutely,
Dr. Seema?
what is not to be done sometimes.
Yes.
It's important to understand that. Yes.
Dr. Seema, please, your comments.
Yeah, Dr. Poonam, it was really very, very good lecture. Really, I must say, you really deserves all the credits for that. The thing is, what I like best in your this thing is one and done. This is really good thing that you stimulate and you just transfer one and keep it for the next future. That was excellent. It is really take home message. And the starting dose of FSH definitely it matters. And basically what three things, age, AFC, AMH, beside that we take in consideration BMI also and the basal FSH level. So that is a more important point when you start the dose. And if you take BMI and definitely the basal FSH level in consideration, you really decide what to start and which gonadotropin to start on. And secondly, I feel LH doses, definitely it also affects when to add LH and from the beginning or from in the mid after 4 injections. So that also give us a quality of oocyte and number of oocyte, we can definitely improve on that. So that is a different thing. And ART success, definitely it is a number of live birth per oocyte transfer. That should be the success rate, and safety, efficacy, and result. All things should go together. That is what I can say. And you all are masters, and thank you very much for inviting me.
And now this ma'am new concept when the patient first time came to you and then the
Yes.
patient taking the baby, how much time?
No, I think that is required a public awareness. That, if you want to have a baby, this is the time you have to do it. Otherwise, you'll end up in things. I think this concept for a public awareness is needed.
Dr. Poonam, this I do always. I always write when first time the patient attended me. This is always written on my prescription. This is the first visit. And I try the patient should get pregnant in 6 months, whatever we need, maybe. So it is always done. Thank you very much.
Sir, before we invite the second speaker, I think, and I just wish to know it, many people talk about LH, addition of LH, but they don't tell their own secrets, how they increase the pregnancy rate. So I think we'll ask Dr. Sehgal to make a presentation next time about this particular presentation. And every myth should be sorted out around LH as far as LH is concerned.